Hello, my name is Megan Mallory, and today I'll be talking about vision and hearing in regards to the aging process. So I'm going to start with an overview of vision. Vision is the leading cause of age-related disabilities. Vision loss greatly affects quality of life, from driving and independence to reading the newspaper. Ebersol and Hess's Gerontological Nursing and Healthy Aging by Tui and Jett in 2018 suggests that two-thirds of those with visual impairments are over the age of 65, and 70% of those with severe visual impairments are over the age of 80. Vision loss can be functional or structural, and I'll talk about that a little bit on the next slide. So changes that affect vision with aging: eyelids lose elasticity, also known as synoptosis or drooping of the eye. There's a reduction in the number of goblet cell secretions. This decreases the tears in the eye and the lubrication of the cornea, which leads to dry eye and the need for artificial tears. There's a reduction in the number of rods and associated nerves, decreasing peripheral vision. There's a decrease in responsiveness of pupils and lens changes, decreasing accommodation, and an increased need for light to see. The cornea becomes thicker, flatter, and loses flexibility, increasing vision at farther distances, whereas presbyopia can also occur, decreasing near vision, making it a necessity for people to use reading glasses or magnifying glasses to see. An assessment of vision. Before assessing the eyes, it's important to get a health history. Ask about family history of glaucoma, cataracts, vision loss, retinitis, because these are genetic and can directly affect vision. Ask about medications like digoxin that can have side effects that affect vision. Ask about environmental factors like chemicals, fumes, and flying debris. Do they come in contact with these? Do they wear eye protection when around these factors? Ask about computer use. Computer use is more prevalent in our society, and research tells us that prolonged computer use can strain the eyes and affect vision. Ask about smoking history. Smoking increases the risk of vascular disease and leads to blindness, as well as ask about glasses or contacts they might use. When assessing the eye, inspect the area around the eye as well as the eye itself. Inspect for excessive tearing or dryness. The eyelashes should turn outward and may sag in older adults. If the lower eyelid turns outward, also known as ectropion, tears don't bathe the cornea and lubricate it properly, and the eyes can become dry. Whereas if the lower eyelid turns inward, known as entropion, the eyelashes can scratch and irritate the cornea as well as decrease vision. When assessing the eye, the sclera may appear yellow in older adults due to lipid deposits in the eye. The cornea should be clear. If the cornea is cloudy, the patient might have cataracts. The cornea should appear convex and the iris should be flat. The anterior chamber decreases in size and capacity with age, leading to increased intraocular pressure, so they might feel pressure, constant headaches, or pain. The lens begins to scatter light, decreasing color perception and increasing glare. The retina will also appear less distinct and more dull. So the pupil should be equal, round, reactive light, and accommodating, also known as the pupillary reflex. Older adults will often have decreased responsiveness of the pupils and changes to the lens, which will decrease accommodation and increase the need for light to see. The Snellen chart and the confrontation test are two tests used to assess vision. Snellen test assesses near and far vision and should be used with and without corrective lenses, whereas the confrontation test will assess their peripheral vision. So some pathophysiology of diseases that affect their vision. First, cataracts. Opposed to a clear lens, a patient with cataracts will have a cloudy lens. About 70% of patients older than 70 will have cataracts to some degree. Cataracts form gradually and painlessly and are characterized as blurred or cloudy vision. They're often unnoticed until they become more severe, and they are often treated surgically or they are removed and replaced with a plastic intraocular lens. Glaucoma is a second type of pathophysiology that affects vision. It's a group of diseases. The most common form is primary open-angle glaucoma, which affects peripheral vision initially and often goes unnoticed. Angle closure glaucoma is not as common and is caused by an obstruction of the aqueous humor by the iris. The intraocular pressure will increase quickly and cause redness and pain. Glaucoma can be controlled with medication if detected early, so it's really important to get a family history on your patients. It is characterized as headaches, poor vision and low lighting, decreased peripheral vision, fixed and dilated pupil, and frequent changes in eye prescription. Diabetic retinopathy is caused by increased vessel permeability in patients with diabetes. Macular edema will occur due to the increased blood and lipid accumulating in the eye, When the disease advances, new blood vessels form to replace the old ones, but damage more easily and hemorrhage. It's common in patients with type 1 diabetes and less common in patients with type 2 diabetes. Diabetic macular edema is caused by thickening of the center of the retina. It's a common cause of vision loss in diabetes patients and is the leading cause of legal blindness. Age-related macular degeneration is a decrease in central vision as well, leaving only the peripheral vision intact. It will begin with blurred vision in a certain area in the central vision and can progress and grow into blank spots in the central vision. Finally, detached retina has to be treated as an emergency or the vision can be completely lost. Small areas of the retina will begin to tear and can lead to detachment. This can occur after trauma or surgery, such as cataract removal, or it can be spontaneous. It's common that people describe detached retinas as an increasing number of floaters in the visual field or light flashes. So now I'm going to talk about some education with vision. So older patients will need increased light, so you want to keep the area that they live well lit, or else they might have an increased risk for fall. In addition to increasing light, you want to decrease glare. The best way to do that is the material the floor is made out of. Hardwood floors are typically the best because they reduce glare and decrease the risk for injury. You always want to use eye protection. Eyes are very sensitive to light in foreign bodies. In order to protect the surface and inner structures of the eye, protection like sunglasses when walking outdoors or safety glasses when working with chemicals or wood or metal can protect the eyes from preventable damage. Because vision loss can go unnoticed due to gradual onset, it's important to have eye exams annually or earlier depending on vision changes. And issues with eye structures or vision commonly go untreated because of the gradual symptoms. In some cases, early detection and treatment can prevent damage and visual impairment or loss. It is in the patient's best interest to inquire about their vision before the effects are irreversible. In regards to the elderly, family members should be on the lookout for symptoms like vision issues, frequent headaches, squinting, complaints of eye pain, and redness. So now we're going to talk about hearing. Due to hearing loss being gradual most of the time, it can go unnoticed. Men are more likely to have hearing loss than women. Some contributing factors to hearing loss are ear infections, noise exposure, smoking, chronic illnesses like diabetes and heart disease. Hearing can be conductive or sensorineural, which I'll talk about later on the next slide. Some changes that affect hearing with aging. Shrinking of the cerumen glands causes thicker, drier cerumen, increasing risk for impaction and irreversible conductive hearing loss. Stiffening of the joint between the malleus and the stapes is known as presbycusis and is irreversible sensorineural hearing loss. Hair becoming coarse and stiff and narrowing of the auditory canal both lead to an impaction and decreased conductive hearing. The tympanic membrane will look dull and gray instead of shiny, as you see in younger patients, and the patient might have altered balance due to changes in the vestibular apparatus, increasing the risk for fall or injury. So, in addition to assessing the eyes, you want to get a health history when assessing the ears. Ask about hearing loss, tinnitus, pain, discharge, dizziness, any falls or head injuries. Ask about family history of hearing problems. History of hypertension or diabetes can also affect hearing. Ask about their occupation if they're around loud noises and if they wear ear protection. And finally, ask about medications they might be taking that can affect their hearing loss, like antibiotics. So when you're assessing the ears, observe the outer ear. In older adults, the auricle may sag and be covered with coarse, stiff hairs. Inspect the auricle for lesions, drainage, nodules, or redness. Palpate the tragus for sensitivity and inspect the auditory canal. Older adults may have narrowing of the auditory canal and thicker, drier cerumen or earwax. Pull the top of the auricle up and back to inspect the tympanic membrane. Older adults' tympanic membrane may appear gray and dull as compared to younger patients. Two types of hearing loss, conductive and sensorineural. The whisper test is a simple way to inspect for hearing impairment and needs additional investigation to confirm. If the patient is unable to hear the numbers whispered in the hearing test or in the whisper test, they may have high-pitched hearing impairment. Using a tuning fork, the Weber's test will distinguish between sensorineural and conductive hearing loss, whereas the Rene test compares air to bone conduction. Some pathophysiology of diseases that affect hearing. So there's two sensorineural hearing losses, presbycusis and noise-induced. Abnormality of the inner ear or by associated nerves cause sensorineural hearing loss. Presbycusis is an age-related hearing loss and is irreversible. The The pathogenesis is believed to originate in the cochlea, but the pathophysiology is unclear. Noise induced is caused by direct damage to the sensory hairs in the cochlea and is caused by constant noise exposure and is permanent but preventable. Conductive hearing loss is an abnormality of the outer or middle ear. Cerumen buildup is a blockage of the auditory canal and is a common cause of conductive hearing loss. Cerumen can be removed by irrigation, cerumenolytics, or manually. Perforated eardrum is another way that conductive hearing can be lost. Some education that for older adults related to hearing. Some manifestations they may have is answering questions inappropriately, asking others to speak up or repeat themselves, having frustration with others when speaking. If a family member is suspected to have a hearing impairment and when speaking with them, you want to sit across from them and speak clearly. Speaking to a person with a hearing impairment loudly can come across as yelling at them and can make the speech unclear. Noise control is very important. With hearing loss can be prevented or reduced if noise is controlled, and always wear ear protection. Cleaning techniques is really important. Q-tips are contraindicated. They can cause the cerumen to be pushed back into the ear and cause conductive hearing loss. Cerumen can be removed through irrigation, cerumenolytics, or manually. There are some ototoxic substances that can affect hearing, like loop diuretics, antibiotics, and chemo drugs. If a patient is taking an ototoxic drug, they should be monitored very closely for changes in their hearing. There are many different kinds of assistive devices that can aid in hearing loss, like hearing aids, speech reading, sign language, cochlear implants, and listening devices that aid patients that might have some degree of hearing loss to revert back to a normal state of life. Thank you for listening to my presentation.